prophylactic use of ACE inhibitor and carvedilol did produce a combined endpoint benefit, but it's, to me, surprising to see the morbidity in the placebo group. That makes me uncertain about the generalizability of that data. Bonnie Key's recent abstract showed was in a similar population and had a fairly low morbidity in the limited scope. So I do think there is a randomized trial that suggests anthracyclines can have toxicity prevented with across-the-board use of carvedilol and ACE inhibitor, but I think there's some cautions about that trial that make it perhaps less useful for the entire world than it might have been.
I see.
No, I mean,
go ahead.
I think most of us believe that there's probably a value, but it's purely it's a belief. It's not. There's no real evidence. I mean, if you want to get people to think about it, you may want to just amend that statement to say that people who are on antihypertensive medications, they should be selectively switched to these before chemotherapy.
That's a good point. So we would say that there's some evidence to support prophylactic treatment, but it doesn't seem to be even level C, right? And that we would encourage that patients that are, I hear a little girl, that we should consider switching to the correct beta blocker or an ACE. If someone could mute, there's a little girl speaking, and she's got a sweet little voice, but if someone could mute their mic for that, I appreciate it. It must be somebody calling in from home. So basically we're going to say, go ahead.
I'm sorry, this is Boaz. I just, I'm not sure if this was mentioned. I had to step out for a second. But there was obviously this, I think, a very important publication from Cardinale et al. I think this was Circulation 2006 on the value of prophylactic treatment for prevention of drug-induced or cardiotoxicity heart failure.
Here's the reference.
Yeah, I can send it to the group right now.
Okay, thanks.
And what basically did that state?
Well, they showed first the time element, and B, the fact that treatment with AC inhibitors, I think that this was an Alapril study, did prevent heart failure in susceptible patients if started early enough. So in terms of time, it showed that if you started immediately or within 1 month, I think that 80 or 90% of cases would be prevented. And if you started after 12 months, 0 would be prevented. And between them, there is obviously a gradual decline in the effectiveness of the treatment. I'll send it, I'll dig it up and I'll send it to the group. Right.
Okay. And so was this a good study in terms of randomized controlled study with a large number of patients?
I can't tell you offhand. Again, this is coming from the Milan group, so usually it's a very good methodology, but I'll have to open the document and put an appropriately designed prospective randomized trial.
If that's the same trial I'm thinking of, what was that not in patients who had a troponin rise?
Yeah, that's correct.
In the they did that basket of troponin checks from immediately post therapy to 48 hours out, and did find that in that population marker positive, that immediate treatment yielded a benefit. But that's more of a, you'd have to say that once you've had a marker positive, that's not truly prophylactic. That's therapeutic with injury in progress.
think that's correct. I remember that, and it was troponin positive compared to the control group of troponin negative.
But I think that is.
You're right.
But I think it's important for us, to say that there is an increasing body of evidence suggesting that prophylactic therapy, and I do think we have to list if level of evidence B, if I'm not mistaken, is one randomized trial, is it not? Isn't that what B is, and C is expert consensus?
Website.
Is that correct?
That's my understanding. That's my understanding.
And I think there's reluctance to accept that Overcome trial, single center, as a capital B. Perhaps it might be level of evidence small b, but I do think there is a body of knowledge suggesting that either treatment with any evidence of marker positivity does provide an indication for probably dual agent therapy, ACE inhibitor, generally carvedilol, and that there's a suggestion that prophylactic therapy across the board might be helpful, but I think it's premature to recommend prophylaxis without further studies.
That sounds reasonable. So,
Eric, can you hear me?
Go ahead. Yes, I can hear you.
Oh, awesome. So I think talking about prophylaxis, I wanted to bring the paper from Cardinale in JACC 2010. Basically, what concerned me in that paper is that if the ACE inhibitors are started after 6 months of diagnosis of cardiomyopathy, the recovery is pretty less compared to if started within 2 months of onset of cardiomyopathy. So we have to, I'm not sure how that would imply in the prophylaxis sense, but that would also tell me that beginning treatment as early as possible might be helpful. And what I'm doing in my practice, I just actually saw a patient exactly with the same issues, is that changing the antihypertensives to ACE inhibitors and carvedilol. So that may be a recommendation that could be made.
Yeah. By the way, Eric, I found a paper. I'll send it in a minute. This was a randomized prospective study in 473 cancer patients receiving high-dose chemotherapy, who were randomized to receive enalapril, yes or no. Treatment started 1 month after high-dose chemotherapy, and they showed a significant reduction in left ventricular ejection fraction, increase in end-diastolic and end-systolic volumes in untreated patients as opposed to treated patients. And again, I mean, the time element was critical. So those who started within 1 month showed most benefit. Those who started after 12 months showed no benefit.
And were these troponin positive?
Yeah, they were all troponin positive.
Yeah.
And I don't have that reference in front of me, but as I recall, they waited until treatment was completed with the anthracycline before starting the therapy. Is that not correct? They did not start with the positivity of the troponin, but at the completion of therapy and not specified duration. Is that correct if you have it in front of you?
Yeah, I think that you're correct. I'll have to read the methods for this, but they started it within 1 month, which, as you said,
but guys,
very likely.
This is not prophylactic in people who don't have any biomarkers and have normal ejection fraction before treatment. It's a whole different class of people.
Right.
This is Amit Yusuf from Houston. I'm sorry, but I might have come in late. Are we talking hypertension, or are we talking prevention of cardiomyopathy?
We're talking prevention of cardiomyopathy.
How come hypertension came in the discussion then?
Well, we said that if patients are coming into chemotherapy and potentially cardiotoxic drugs, and if in fact the patient has a risk factor, i.e. hypertension, and is on antihypertensive medications, would it not seem reasonable to switch their medications over to an ACE and to carvedilol? And so that was the proposition.
I do that in my practice.
Yeah, I do that also.
So we all agreed that that's reasonable.
The evidence behind is only one paper that probably came from Italy, and there's one paper that came from Turkey, where they gave people both they gave them core egg and it prevented cardiomyopathy, rather decrease in ejection fraction. So I don't know if we can base this evidence on a lot of randomized trials. We can say it's consensus.
Yeah, that would have to be a C, but I think it's worthwhile to put in there. The level
So
of
that
evidence.
might also come into just treatment of risk factors rather than prevention of cardiomyopathy. You see, we are treating hypertension. We're not treating prevention of cardiomyopathy.
Yeah, but you have a lot of choices when you're treating hypertension, and so I think that we're saying that when you're using these potential choices, you'll pick drugs that are also cardioprotective rather than drugs that are negatively inotropic. I mean,
Agree 100%, yep.
I think we should say that.
So I think we're all in agreement that if there's a pre-existing reason for antihypertensive medications, that we use drugs that would be protective in patients who are getting potentially cardiotoxic chemotherapy. So everyone agrees on that premise.
Yeah, Eric, my only comment here is that we are going to discuss hypertension later on, either next time.
Yes.
So there may be some overlap here. I would say that I would agree with this, and I also agree with the comments and criticism that this is not truly prophylactic. It's more sort of post-fact, but nevertheless, I think that there is a level of evidence showing that treatment with AC inhibitors in these circumstances does have beneficial effect. How do you start them? When do you start them? And who are most likely to respond? I think that this is an open question on prophylactic issue.
This is Sushmita Parasha from Emory. For the prophylactic treatment, I would take out the word should be considered. I would say may be considered.
So may be considered. That's correct. That sounds like a good proposition. So we have Susan Dent keeps trying to get on, but for some reason she's not been able to resolve her microphone issues and continues to be muted on her computer, but not by me. So I just want to make that statement if Susan can hear me.
No, I had similar problem. Tell her to go on the telephone. I'm on the telephone.
Okay, great. Different people have to take different steps depending upon their computer system and the microphone function. Okay, so that's great. So in terms of the prophylactics, I think we've made a statement here that we can work with. And so let's go, and we'll have that for next time to review. Let's go to the next piece here under prophylactic, where what are IAs? Said IAs for the general population.
I think it's a typo.
Excuse me?
Maybe it's as for the general.
IAs for the general population in cancer patients with an abnormal ejection fraction. Medical therapy with an ACE inhibitor, ARB, or beta blocker is recommended prior to anthracycline treatment. So greater than 40% ejection fraction. I don't know where that came from. The greater than those with EF less than 40% is recommended that anthracycline is not recommended. So I guess this is a cutoff for anthracycline that must be already defined in the literature. And then we're talking about in the general population in cancer patients with an abnormal ejection fraction of greater than 40%. So I guess they're trying to say less than 55 but greater than 40 and then less than 40. And so they're recommending that if they're starting on, if they're getting anthracyclines, that they be on these drugs. That would be prophylactic therapy for somebody who already has a cardiomyopathy of undetermined etiology, I guess.
I wouldn't call it prophylactic. That's standard of care for heart failure patients.
Yeah, I don't call that prophylactic either, so I agree with you. that that's not prophylactic. So what we'll do is we should probably delete this from this section and put this somewhere else. So we'll delete this from this section and put this somewhere else. So let's move on from the prophylactic treatment. We'll take this out of there since that doesn't belong there. Okay?
This is Vamik Yusuf. What is confusing to me is the fact that abnormal ejection fraction greater than 40%. Is it between 40 to 50%? I think this statement has come from trastuzumab section, where if somebody's EF is less than 40%, on therapy you can give them a trial of trastuzumab, not for adriamycin. So I think it's, somebody has put it wrong here. Hello?
We're going to delete the whole section under prophylactic. It doesn't seem
Yep.
It doesn't seem to be appropriate. And let's move on to the next area. If everyone's in agreement, we can move on to the next area.
One more. I'm just being more careful here. I'm in the process of writing a grant on this, so I'm just being very careful with all the wording we have. So in prophylactic, we said it said it should be considered to reduce the risk of cardiotoxicity. Since our level of evidence is so low, I would be very careful about that. So I would say it may be considered to potentially reduce the risk of cardiotoxicity because we're not really sure about it.
Yeah, we've got that at a level C, so putting it at a level C probably does enough hedging words in terms of may and considered and could be. And so I think level C takes us down to those kind of words anyway.
Okay.
So let's go on then into the next section. And I think we beat this one up pretty good. And so coming down to during cancer therapy, cardiac safety surveillance. The following general principles are recommended for medical imaging in patients with cancer at risk for cardiac complications, particularly for the periodic assessment of left ventricular systolic function. And so we've got number one, or bullet one, highly reproducible quantitative volumetric non-irradiating imaging with quality control is preferred, level A. Any discussion? That's like the Holy Grail, it looks like. So, highly reproducible, that sounds good. Quantitative volumetric, that's more than just an M mode. That would be like two-dimensional or maybe three-dimensional if you've got that. Non-radiation kills the mugga, which we don't like anyway. And so that gives us MRI, or gives us echo, mostly echo, but for patients that can't have an echo, it gives us MRI. And then imaging with quality control, well, we have patients that go to imaging centers where there's no physician supervision and where there's non-cardiac techs doing an ultrasound image, and it's the lowest bidder, and they're able to do that test and come out with a 12 to 15% drop in the ejection fraction, and then we've got to redo it. And so that sounds good and is preferred, probably more than preferred, I would say is required personally, but I'd like to hear what you guys think about that.
So, you know what, I had to walk out for a second. We did this last week or 2 weeks ago. This was like already done.
I'm sorry, I didn't. I took off where I thought we left off, and
I thought we already did this.
okay. So if we already did this, we can move on. So where do we go next? Some of you were present somewhere. Where do we go next?
I don't know, but we did do this.
All right.
Same thing.
How about
We
the?
always do.
We did all that.
That's what we always do.
Serial global. We got that. Oh yeah, because it's got
we
level.
did that whole.
So
we
we're
did
on
that whole box.
How about the next block?
We did not do that.
Okay, so let's take this one. Asymptomatic patients undergoing anthracycline treatment with no laboratory abnormalities should undergo routine surveillance for the early detection of cardiac toxicity consisting of. Okay, and what do they mean by, what do we mean by no laboratory abnormalities? I'm not sure what that says.
Probably biomarkers.
So if you've already
We want
got,
to be specific with no
With-
troponin or BNP elevation.
so with no elevation, we'll change that, with no elevation of BNP, NT-proBNP, or troponin, should undergo routine surveillance for the early detection of cardiac toxicity consisting of. And so actually this is somewhat self-fulfilling in that they've already had the BNP and the troponin as a baseline. So are we recommending, have we recommended that as a baseline previously? And then we're carrying on about what to do afterwards?
Eric, this is Amit Yusuf. I think we can take this word no lab abnormalities completely, because what is outlined below is every 3 to 6 weeks and prior to each cycle. So I don't know where this, why would you have a high BNP to start with? Why would you have a high troponin to start with?
And also that's already doing surveillance. And so why don't we just take that out?
Yep. You
And
just
the
put on
periodic
asymptomatic patients undergoing anthracycline treatment should undergo routine surveillance for early detection of cardiotoxicity.
So should we say, yes, let's take that out, and then we say baseline and periodic. How about that?
Yes. Yep.
You want to change that to baseline and periodic every 3 to 6 weeks or prior to each cycle measurement of troponin, I or T, B-type natriuretic peptide.
Hey, Eric, I think
Yes, go ahead.
we already have that. We have a baseline assessment, and we've already outlined further up.
Okay. So now we're
and already
going
talked
to
about it. Yeah, I think at the last session. So I think now we're more into sort of the follow-up stage and surveillance. You know, after we had our baseline. So he may have been suggesting no laboratory abnormalities at baseline should undergo routine surveillance.
So this is the moving on from baseline, which we've already
Right.
outlined. Then this is surveillance beyond that. And so we could say with normal BNP, blah, 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 should undergo surveillance, early detection. And so here's our surveillance. Every 3 to 6 weeks or prior to each cycle, measurement of troponin I, blah, 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 BNP. And are we recommending both? Well, and as I think I stated last time, you'll be able to get a troponin at Walgreens for $7 and a BNP for $24 at Walgreens. And so 24 and 7 is 31. That's not a lot to spend each cycle, $31. Especially looking at the price of chemotherapy. Go ahead.
Are we taking into account the national, lab variability nationwide or internationally?
I believe that we're saying within the context of your own laboratory, and so I guess we'd recommend that you get it done at the same place each time, the same lab each time.
Right.
So within the context of your own laboratory milieu, and that you repeat it at the same laboratory. So we'll make a statement about that using the same laboratory. Should we move on to 2? This is reassessment of left ventricular.
Eric, can I stop here? So what if your baseline is abnormal? Where do they go?
Okay, then we'll have to talk about that. So
Okay.
let's take that for a different box.
Another day. Okay, done.
Another box, different box. Okay, reassessment of left ventricular function following general imaging principles after a cumulative dose of 240 milligrams per meter squared or doxorubicin or its equivalent anthracyclines after each additional 50 milligram per meter square at the end of therapy, even if less than 420. So are these numbers cast in concrete?
We use 300. And I think there's a typo also that after meters squared, that probably is OV, not OR.
Yeah. So,
the reason we picked 240 was because that the standard AC regimen for breast cancer hits at 240. So that was sort of the rationale for picking that number.
Okay.
But that's signaling out the anthracycline and not staying, if, say, the patient's on tocilizumab as well, that might not be operant because of the synergistic effect.
Not given together, so it's never an issue.
I see. Okay.
They're sequential, not concurrent.
Yes.
The next box looks like it's supposed to address trastuzumab, so I think we're kind of going on a single agent sort of basis here.
Okay, and so our maybe combination. Maybe at some time we'll hit the combination. Okay, so we got the signal agent, and we recommend using those doses. Is that pretty much? Are those doses absolute, or can it be that you have much less incidence of cardiotoxicity, but you still can have it? Is that correct at a lower dose?
Yeah, according to what I've read, there is the statement from actually Dr. Lenihan's paper is that no dose of doxorubicin is safe. It looks like even lower doses can result in cardiomyopathy.
So therefore
Which paper from Lenihan?
Yeah, this is
This is Amit Yusuf from Houston. Which paper from Lenihan?
There's a cardiac toxicity in cancer survivors. It's a
Is it a review paper?
It's a review paper in American Cancer Society 2013.
So does everyone agree that that it's not limited to above a certain dose, or that you get cardiotoxicity with anthracycline? It's just a decreased incidence? I mean, certainly patients that have lots of risk factors are going to be at greater risk.
I hesitate to put a dose, like such an absolute dose number. You know, I think it just makes it so as if we have a lot of evidence at this dose and not below or above.
You know, this is Charlie Porter. I had to step away. There was a paper, I think last April in JACC, looking at late survivorship on kids, pediatrics, anthracycline recipients, and their average dose was 250 mgs, and only, I think, 20% of them had a normal EF using cardiac MR at 55%, and if you looked at their reference population, the confidence limits of the reference population, which was mean of 65, did not even overlap with the treated group. So what they were calling normal for the treated group was did not even overlap with their reference population EF. So I don't know. I mean, it's hazardous to extrapolate from the kids to adults, but that suggests that there's toxicity that it's pandemic almost. At least if you read that, at least in the way I did with the statistics, which might have been incorrect. Did anyone else look at that article? It was just very compelling to me, suggesting that there's toxicity that's subclinical in a fairly widespread manner.
So, Charlie, it's Joe. There's two different issues here. The issue, I think, for this box, and maybe we have to clarify it, is during treatment. I think that there's a difference between what you do during treatment and ultimately what we're going to recommend after treatment. So this is just during treatment. When you get to 240, the curve, might begin to become more steep. It doesn't say anything that it's safe up to 240. All it's saying is where you should be in monitoring. Two different issues.
Thank you. Well, I think 240 would be a good place to check. I mean, seems that it's
And that's sort of current standard practice in all of the breast cancer trials. That at the end of anthracycline treatment, which is generally 4 cycles of 60 milligrams per meter squared each, that before going on to anything as the next step, that they generally look in a trial at the ejection fraction by echo. So that's why the 240 floated in there.
So it's everyone sort of agrees that we should use these numbers, or we should just say anthracycline and not put numbers in at all. What's your feeling?
I think we need to put a number in.
Put in numbers. Everybody want to put in numbers? Do I hear from anybody else about putting in numbers?
I think we need to put a number, but we need to look at it and find out what is out there before we actually put the numbers.
Okay, so
I agree. I agree.
Okay, so let's look at the numbers and come back on this one once we have a general approval of the numbers. And
Joe, I have to go. I'm sorry.
yeah, we all have to go now because we've exceeded the 10 o'clock time. So thank you so much for coming, and anybody who had microphone problems, please get in touch with me. My phone number is 813-323-5447, and we'll do a test to find out why the mic wasn't working. Okay, thank you so much, and look forward to next week.
Thank you all. Thank you, Eric.
Bye, everybody.
Thank you.
Thank you. Bye.
bye. Thanks.
Bye.
Thanks. Bye-bye.
Hey, Eric said that it's a case next week, not a conference.
Oh, that's right. It is a case next week, not a conference. So we'll skip next week and come if you want to come to the case, which starts at 9.
Okay, perfect. Thanks a lot, Eric.
Thank you.
I think
Bye.
Thank you, everybody. Bye-bye.
Okay, thanks a lot. See you on next week.